A 32-year-old male presents with deep progressive thigh pain. I am showing you the radiograph of the femur. Describe the findings.
Okay, assessing the provided imaging. The radiograph of the femur demonstrates a large, lobulated, cauliflower-like ossific mass arising from the femoral shaft. There is a fine radiolucent line separating the main body of the ossific mass from the underlying bony cortex, representing the string sign. The mass is attached to the cortex via a broad-based bony stalk, and there is mixed sclerosis and lysis. A small amount of non-aggressive periosteal reaction is also present, but the medullary canal appears spared on this projection. These features are highly characteristic of a parosteal osteosarcoma.
What is the differential diagnosis for a juxtacortical bone mass, and how can we differentiate them?
Okay. The differential diagnosis includes a benign osteochondroma, myositis ossificans, juxtacortical hematoma, and extraosseous osteosarcoma. We can differentiate an osteochondroma because its cortex and medullary cavity are directly continuous with the parent bone. Myositis ossificans demonstrates a peripheral pattern of calcification with a lucent center and is usually separated from the cortex, lacking a tumor stalk. Extraosseous osteosarcomas are entirely soft tissue lesions that do not attach to the cortex. Conventional osteosarcoma is easily distinguished by its medullary origin and aggressive sunburst periosteal reaction.
I'm showing you comparison radiographs of other osteosarcomas. Describe the findings and compare their features.
The first comparison radiograph shows a parosteal osteosarcoma of the distal radius in a child, presenting as a dense juxtacortical lobulated mass. The second comparison radiograph demonstrates a conventional osteosarcoma in the distal femoral metaphysis of a child. This conventional osteosarcoma demonstrates aggressive features including mixed osteolysis and sclerosis, cortical destruction, a huge soft tissue mass, and a sunburst periosteal reaction. Conventional osteosarcoma originates from the medullary cavity and is highly aggressive, whereas parosteal osteosarcoma is a slow-growing surface tumor.
Discuss the epidemiology and clinical prognosis of parosteal osteosarcoma compared to conventional osteosarcoma.
Parosteal osteosarcoma is a rare subtype originating from the outer periosteal layer, accounting for 4% of all osteosarcomas. It is slow-growing and tends to affect older patients, with a peak incidence in the late 30s, whereas 75% of conventional osteosarcomas occur in patients under 30. It also has a female predilection of 3 to 2, whereas conventional osteosarcoma is more common in males. Crucially, parosteal osteosarcoma has the best prognosis of all osteosarcomas, with an 80 to 90% 10-year survival rate following wide surgical resection.
How would you manage this patient as a radiologist?
In that case, as a radiologist, I would recommend comparing these radiographs with prior studies to document the growth of the juxtacortical mass. I would recommend a dedicated MRI of the femur to evaluate for any medullary canal invasion, which is critical for surgical planning. I would also suggest obtaining a chest CT scan to screen for pulmonary metastases, which can occur despite its slow-growing nature. I would immediately communicate the diagnosis to the referring clinician and refer the patient to a specialized orthopedic oncology multidisciplinary team.